And down to our last leg today, day 2 of the joint conference, the final 2 hours. At this time, I'm deeply honored to introduce our next speaker, Dr. Michael Sauri, who's one of my mentors and also a dear friend. I rotated with him in his clinic in Rockville, and it was one of the most memorable experiences of my life. I still talk about it. He's a specialist in occupational medicine, infectious diseases, and tropical medicine. He's been a clinical professor at Johns Hopkins Bloomberg School of Public Health and the Uniformed Services University of Health Sciences, and has received numerous accolades as he's been repeatedly recognized as a top physician in the Washington, D.C. area by both patients and physicians. Dr. Sauri.
Thank you for that. That was very nice. Nice to be here again. I think this is going to be my swan song because I closed my practice in January. And that, I think I did leave at the right time. But I went back into work. 2 days ago, I was given my formal job acceptance, so I will be in Defense Health Agency Region 6, so as an occupational medicine physician, civil servant, and they oversee 26 states west of Mississippi, so you might want to wish me luck. Well, this particular talk is, I gave some of it in 2023, was focused on emerging and re-emerging diseases. But I wanted to talk about just a few of those slides that I presented then to give you an idea of what I really mean by emerging and re-emerging diseases, because really the talk is about how do you, as an occupational physician, manage exposure in a biomedical research environment. And you're going to find that in medical centers, you're going to find it in universities and in the private sector, where I spent a couple of decades working with 150 biotech firms in Washington, where I did see every slight patient exposure, either in the military, when I was in the military, or in private practice. So I think that my mentor in microbiology, when I majored at the University of Texas, Glenn Savage, his mentor essentially was Rene Dubois. And I think his quote, since the days of the caveman, Europe has never been a Garden of Eden, but a valley of decisions, where resilience is essential to survival. To grow in the midst of the danger is the fate of the human race. And I think that it has our acceptance to these emerging diseases, or lack of acceptance to the onset of these emerging diseases. There's an auto. Can I get rid of that one?
I'm sorry?
There's an auto progression that's on the slide.
Oh, it is?
But essentially, our grandparents were used to seeing situations where a friend didn't show up the next school year because they died of TB or they died of flu, and this was just the reality of life. I think our current generation isn't used to that. You can't accept that type of threat. In fact, there's a zero tolerance, as you might hear a lot about it, to any type of death due to a preventable or non-preventable condition. But I think when you talk about zero prevalence, you're really ignoring sensitivity and specificity of our treatments, of our vaccines. It makes it totally unrealistic to achieve that goal of zero tolerance. So I think that we're kind of in a quandary here, conundrum, because we really have to be tremendously transparent to the general population about what we know and what we don't know. And as you know, that's where we failed in COVID-19. And I've been an epidemiologist in the Air Force investigating outbreaks worldwide. I've been chief of infection control for 20 years in my local hospital, a tropical medicine consultant for the military. And the reality is that these emerging diseases are inevitable. We're never going to get to the point where we don't run across them. And I wanted to emphasize in these pictures that I'm going to show you the reason why we have to deal with this and why this is not, it is a clear and current danger to us, and we just have to deal with it. So, as an infectious disease specialist, the first thing you realize is that epidemics are normal and natural. And infectious diseases have had a major influence in human history, but our collective memory of these diseases is short despite mankind's long association with infectious disease. These PowerPoint slides are available to you of this 2023 talk I'm giving. So just to let you know, Global Health WHO has identified what they consider the 10 top threats, of which you'll see a lot of them are kind of emerging diseases. Though Fauci, who was my instructor in infectious disease, did a nice summary of the major emerging diseases. These are just the tip of the iceberg of emerging diseases. You can look at the reasons why they develop from an epidemiological standpoint. If you look at the triad of agent, host, and environment. And what I want to do is go into reasons. Okay, so global travel is one reason we'll always have this disease. And if you look at this picture, if I can turn it on. What you're going to see is that the sun is moving to the east. And these are all the airline, scheduled airlines that are going throughout the world. And if you notice that it gives you an explanation of why Ebola really didn't hit the US that much, because there weren't any direct airlines to the US. With Lhasa in the Midwest, we have a lot of Sierra Leone, a fairly good component of Sierra Leone natives in the central area of the US, so we see Lhasa fever occasionally. But these are factors why there's disease in various places has to do with travel. The other thing it has to do is global urbanization. It's like having a childcare center and having disease magnify within or amplify within a setting. You'll see like Central Park, and that seems like an example, but this is when I was flying, I was a pilot, so when I was flying a 182, this is the same picture of New York City. This is what I mean by urbanization, the concentration of populations. This is why when 10,000 Bosnians came over, when Clinton decided that he would bypass the standard sanitation regulations, they all went to Brooklyn. 3 months later, in the bird reserve just south of Kennedy, the blackbirds started to fall out. Started to fall out of the ground because West Nile was in Bosnia, and you had a lot of febrile people who weren't screaming like they would normally have been screaming. And now, and within a year, it's throughout the entire United States. Overpopulation, this type of reality is something that just makes it impossible for us not to have to deal with emerging diseases. When I talk about re-emerging diseases, I'm really talking about the fact that we haven't seen it for, over 35 years. An example would be like malaria in Arkansas, which happened this year. I'll give you some examples that will update this list that I've been building up over the years of emerging diseases that we have seen constantly, and most of them don't make the news, but they exist. So let me just switch over, if I can, Keith, to the next.
Oh, are you done? Okay.
So I won't go into emerging diseases, but we are talking about in this topic, how do you manage exposures in a lab, hospital, medical center to these emerging diseases? And frankly, in a lot of primary facilities, they're going to deal with these diseases before it's even reported in ABC and NBC, the media, because they've already been dealing with it. CDC has already alerted, because they're already trying to develop some type of defense against it. So the overview is primarily about what is the biomedical industry, what are the hazards, how do we screen, how do we manage. Some of this was already discussed by the doctors, and I'm not going to go and run through those HIV, but there's some points that I think are worthwhile making. And then there's a list of regulations that are actually in the back, quite a few of them that will give you guidance when you're trying to explain why you need to do this or what is the current method to protect the worker from these agents. So these are the newest emerging diseases that have occurred since 2023, since my last lecture on this topic. And if you can make it out, the main thing was a recent invasion of invasive mosquitoes. It's Aedes albopictus and Aedes aegypti into the UK, which means that now they have the ability to, if they get inoculated, or if they bring tourists in with dengue, chikungunya, Zika, UK could be affected. Measles outbreak in North America, and I don't just mean the US, but Canada has been hurt worse than we have in Mexico. Yellow fever and a novel Oropouche virus, which is similar to dengue in South America. Dengue and chikungunya, which has been rampant in India and Brazil. We have a multi-drug resistant Candida aureus, which is now the super yeast, pathogenic yeast that is spreading through hospitals in Europe and in the United States. Very virulent, very invasive, and not too many treatment options. You've heard about the New World screwworm and the cattle moving up through Mexico, which is actually due to a termination of a policy that Mexico had with respect to surveillance of their cattle. So this is on them. HIV resurgence, not just for the defunding of the president's emergency plan for AIDS relief, PEPFAR, but also there's been a recent apparent craze for IV drug abusers to do, and Fiji in South Africa, called Bluetoothing. I don't know if you've heard that, hot spotting, flash, blooding. What they do is they inject amphetamines, narcotics, and then they pull a little bit of the blood out, and then they give it to somebody else. So they get the same effect. And this is a really horrible practice, but it's by explaining why in South Africa they're getting a resurgence of HIV. And then there's the super bug associated with the war and casualties in the Ukraine, very similar to what we had in our Iraq war, where they are essentially dealing with Enterobacter baumannii. And these are resistant organisms that spread to the hospitals and have very little treatment options. In the US, you've heard about the foodborne epidemics associated with our US grown produce, the Lone Star tick, which associated with alpha-gal disease, and the rabbit tick in Massachusetts associated with an increase in Rocky Mountain spotted fever, typhus in our homeless population, and that's something we've never had. And then clade 1 or clade 1 mpox, also in LA, which is a more virulent form of mpox. Chikungunya, just recently reported in Long Island, now in New York City, and the autochthonous transmission of malaria in Arkansas and adult states after about a 20-year hiatus. Doesn't quite mean reemergence because it didn't fit the 35-year category, but these are just examples. Okay, so what is the biomedical industry? Well, most people in the community only know what they read, only know what they see in the literature and the movies, and so they are already a little bit paranoid about having a biomedical facility, especially a level 4 facility in their neighborhood. And that fear is stoked by the media, and these are oftentimes the agents that are being studied in this area in Washington. There are categories of occupational infections, and the categories are broken down by the method by which the mode of transmission. So I won't go into this, but just to let you know that it is, if you know the type of job that an individual has, you can usually identify the disease, the likely culprit that they're suffering from. And so this simply just goes through the methods of transmission. Oftentimes we see these infections in an occupational setting, military, schools, child care centers, prisons, anywhere where there's concentrations of the populations, enclosed specialties we deal with in travel medicine, veterinary medicine, hospital infection control. And biomedical research is pretty much, we deal with the same problems in infection control in hospitals that we deal with in the biomedical research. The only difference is that they want to have this agent in the environment, whereas in hospitals, we don't want them in the environment and want to keep them out, but they're particularly working with it. So they're only dealing mainly with the host and agent variabilities, not the environment. I'm going to try it. So keeping track of laboratory-acquired infections is really related to what was the technology back in that time frame and what were the agents they were primarily studying or what was of interest. And so based on this time frame, the diseases that were being reported in the workers varied. And I think as back in the 50s, there were particular agents that they were very interested in working with. But if you look on the right column, these were pretty much the methods by which they were getting infected. And the interesting thing is that it really hasn't changed. These are still pretty much the mechanisms by which these people get infected. Pipetting, not obviously, not now that they have autopipetters than manual pipetters, but it's still sharps that are the main culprit, and bioaerosols. They didn't have a concept of bioaerosols at that time, but if you look at what this series of laboratory-acquired infections, a good number of those were actually bioaerosols transmitted. At the present time, these are the big headaches that we have, select agents, and the bacterial agents. We have pandemic viruses, the emerging diseases. I won't talk too much about prions and nanoparticles, but can say that prions are almost impossible to get rid of if they contaminate a facility, and nanoparticles actually turn bioactive. You take silver and make it a nanoparticle, and they become anti-infective. You add a chemotherapeutic agent to a nanoparticle, and it becomes active. The problem is the mass that you are being fitted for are down to 0.3 microns. These nanoparticles are, 100 times smaller. So you're not really protected even with the masks that we use today routinely. So the populations at risk are primarily these that deal with infectious aerosols. I emphasize aerosols because that is our biggest nemesis in hospitals. It's also the biggest thing that we pay attention to in the biomedical arena. But these are just examples of various populations of where we tend to run across infections through bioaerosols. The classic bioaerosol was TB. In fact, most of the regulations that are used in infection control and isolation rooms was based on TB. Unfortunately, they don't necessarily apply to some of the particular agents that we use now. But again, that's where the regulations came from. There are certain bioaerosol generating activities that occur both in biomedical research as well as hospitals. And hospitals have another one that's been my nemesis as a infection control chief for 20 years, and that was decorative fountains and fish tanks, because it seems like everybody wants to put in a nice calming decorative fountain, but those have a biofilm. They can be associated with wound infections and certainly play havoc with our immunosuppressed patients. So when I talk about select agents, back in 2002, the Institute of Medicine was asked by the government to list the worst biohazardous agents that could kill mankind and large populations. So they made a list. Initially it was 20, now it's 67, but these were a lot of the ones that were on the initial list. But because they were selected by the Institute of Medicine, they developed the term select agents. So these agents aren't going to be studied in a hospital. They'll be at a BSL 3 level or a BSL 4 level. So the ones that are interested, and the ones that they work a lot with in the Washington metropolitan area, is anthrax, plague, tularemia, smallpox, botulinum, exotoxin, melioidosis. There are other viruses, the hemorrhagic viruses. Dr. Yassine can tell you, I don't know if he can tell you, but I think there are certainly other viruses that are being studied, trying to figure out how to defend against them. Emerging diseases of interest aren't just the select agents. I mean, we have enough in our hospitals that we have to deal with these multi-drug resistant agents, gram-negative, gram-positive agents, and they are multiplying and morphing and mutating faster than we can develop antibiotics to protect it. And the reality is that there's probably going to be a post-antibiotic age in the next decade, where we're going to have diseases that we really don't have any treatment for. So if you think about the staph, they killed a lot of the infants in the 50s. That's why they developed the incubation hoods for them. They were isolation hood chambers, because they didn't know how to prevent, how to treat the infection. So they were trying to protect the neonates from being touched too much by the nurses. And so, just to give you an example, we're maybe heading back to that type of sad age. So biosafety levels is, it used to be kind of questionable, but I think that we've gotten a little better in trying to define what we actually mean by biosafety level. So the biosafety levels are broken down into 4. And some people, if you go to the movies, in Andromeda strain, they have a BSL 5. There's no such thing. That's for agents. So there is no BSL 5. But to give you an idea, I'll just give you a quick example of the operations. BSL 3 will deal with a lot of these select agents. BSL-4 actually will deal with agents we have no treatment for, but have a significant community risk. And a high mortality rate. So I think just to give you an idea of these types of agents, if you look at how they structure the practice, you can think of when you're at the BSL-3 level, there's a protocol for washing your hands. There's a protocol for donning your mask. There's a protocol for opening up the biosafety cabinet. So everything has a protocol, and you have an observer watching you to see if you're actually doing it. When you get up to the BSL-4, you're essentially a biosafety cabinet facility enclosed in a biosafety cabinet facility. So you have heightened, very heightened security at that point. So BSL-3 would be dissecting a frog in high school. BSL-2 would be what you normally see in hospital settings. And you'll see that biosafety cabinet there. And it has laminar flow to protect you from breathing anything that's in there. It's going away from you. BSL-2 plus, you might see in the microbiology department in the lab, where there's a separate room to handle TB and fungus, because those are very infectious. And so that's about what you see in most hospital setting laboratories. BSL-3 is where you're essentially using what he was describing as a PAPR, positive pressure airway system, and you're working under a hood. BSL-4 is essentially what Dr. Yassine and Samrid and all of the BSL-4 facilities are doing. They're essentially totally enclosed with independent air supply. You certainly have seen the limitations of BSL-4 in the field with Ebola. I mean, even these Tyvek suits were tremendously heat stress to them. They could only work for no more than 45 minutes, and they were essentially having a heat stroke. They had to be taken off, and they couldn't really deliver adequate care to people who were dehydrated, primarily due to losing 40 liters of stool every day. So, give you an example of the BSL-3 facility. If you go up Wisconsin to NIH, you'll see this building from the highway, from the street there, and that is a BSL-3 facility that can actually handle 10 agents at the same time. That's been there for about 15 years. Prior to that, they had one facility. The researcher could use it for a year. They terminally cleaned it. Another researcher could then request a grant to study another select agent, so they could only do one at a time. This one can do 10 consecutively. It's state-of-the-art. It's bomb-proof. This is USAMRID. This is when, just before they reactivated, we had our AOH here in Washington, and I took about 40 attendees on a bus over there so they could see the slammer before they activated it. But we're next to it. This is essentially what a BSL-4 is. It's a biosafety cabinet within a biosafety cabinet. But essentially, they're trying to do everything they can, short of personal protective equipment, to protect the individual, but also to protect the community from the release of these agents. Some of these agents will take out every Canadian geese in Montgomery County. Believe me, if these companies, if that was to happen, these companies would be closed. There'd be an outpour, outrage from the community. So there's most of these companies are very strict about these controls because they really want to stay in good relations with the community. The BSL-4 facilities are listed here. The U.S. has the lion's share of it. These are the the specific list of the BSL-4 facilities in the U.S. The newer ones like Texas Medical Branch in Galveston, the one that's right next to you, SAMRID, with this Homeland Security's National Defense Analysis and Countermeasure Center, and Boston's. Boston took a little time to be clear because they had an unfortunate release of tularemia in that facility that the community got very upset about and delayed its opening for 10 years. This is the biggest and greatest facility that exists at the present time. I was the ID consultant, augmented consultant for Plum Island, and they moved Plum Island to the middle of the United States. So it is now in Manhattan, Kansas. And this only deals with the worst animal pathogens. So anything that can kill all your cows, all your horses, all your domestic animals is in Manhattan, Kansas, rather than in Plum Island. So very high security facility, but just to let you know that that's another, it's not just for human pathogens, they have ESL4 facilities for animal pathogens. So I think the biggest headache I had doing support for the biomedical industry was the animal handlers, because they are really at the highest risk. Physical hazards, chemical hazards, infection hazards, and then not to mention the allergies that are very common in these particular workers. So our clinic was dealing with these types of injuries on a regular basis. There were all kinds of hazards that we had to address, especially in women who were wanting to get pregnant or pregnant women. We had various pesticides, anesthetic gases, ethylene oxide, disinfectants that people were reacting to or got overexposed to. We had various vector-borne diseases, and we dealt with all of these types of exposures. Again, airborne transmission to select agents, TB. These are the types of things that, you're going to get. If you stay long enough in this arena, you're going to have to deal with these types of exposures, whether it's MRSA or you're dealing with people getting dysentery from Campylobacter from the mice or the rats. I mean, we deal with this, and you just have to know what is not the treatment, but the prophylaxis for people who are exposed to these agents. Most of the time, there's an incubation period, so you'll be able to tell if you were successful in your prophylaxis. And usually, they don't come to you sick. But we did have some people who got glanders, got various other diseases, and they went to their doctor. They even went to an infectious disease doctor in another city, and they failed to tell them what they did for a living and what they were working with. And it actually, for the glanders one, it took a fourth-year medical student at Johns Hopkins to make the diagnosis because he asked them medical history. What do you do for a living? And they connected. It's not an uncommon thing. In fact, at Plum Island, since there were two ferries from Connecticut and from Long Island that went to the island, we had to give these individuals a little card to put in their wallet. Each one was individualized to what agents they were dealing with, because when they go back and they get sick, and they see the primary doctor, and they have, their doctor's going to, think of horses if they hear hoofbeats, not camels, and so they need to have a heads up as to, well, maybe there's something out of the box here that we need to deal with. So those are things that are kind of considered standard procedures in the medical arena. You need to help the primary doctor out too. So the medical screening is not really anything different than you normally do, and most hospitals, except that here in most clinics, except that you're dealing a lot with allergies and animal bites. and things. And we give a lot of vaccinations. We do a lot of TB screening. So this is what you'll deal with. We also deal with the workman's comp, the back strains, and the burns and things like that. So additional surveillance that we have to do in laboratory animal workers can be a laser evaluation, DOT CDLs, asbestos-silicosis screening, surety evaluations because of these select agents, fitness for duties, physical abilities tests, and workman's comp. So we give lots of vaccinations, and this is just a list of the vaccinations that we give. You'll see that there's yellow fever and there's Japanese encephalitis. It's not because they're traveling to do field work, it's that they're working with these agents. But when you get right down to it, you have to educate sometimes the companies with respect to what the reality is if these workers get infected with a vaccine preventable disease and you didn't offer them the vaccine. It doesn't go well in court. So you have to encourage them to consider giving these people, or at least offering them these vaccinations. Now, even CDC doesn't mandate vaccinia vaccinations. If you're working with smallpox, they highly recommend it, but they don't mandate it. There isn't any mandate. But it's hard for the law to kind of look good when you could have prevented the infection in the worker. The preventative measures, the things that we try to do, we try to make sure that they have an adequate protection. Preventative measures are in place. There's all kinds of protocols, squeeze cages, that do surveillance on animals in order to try to reduce the in order to try to reduce their exposure. And again, we deal with all of these particular work-related injuries. I will say that we do a lot of surveillance for HIV, SIV, Q fever. Some of the animals that they deal with are not screened. They have potential for rabies. Back in the early period, there was a lot of emphasis for doing serum banking on everyone. That became very cost prohibitive. And now, if you're going to do any serum banking, try to limit it to a very small department like R&D, where the actual wild agent is being studied and hasn't yet been broken down and made non-infectious. That population may be at higher risk, especially if you are studying something that you have no test for, no prophylaxis for, no vaccine for, no treatment. You want to maybe see, and some of the purpose of the serum banking is, are my current procedures adequate? And if you can go and once you have or develop a screening test, you can kind of see, well, yeah, nobody's been getting infected here. There's no seroconversion. Our protocols are adequate to control this agent. Sometimes you really don't know if standard procedures at whatever level you're working with is going to contain this particular agent you're studying. The biggest problem that we had with Ebola is that the people were having 40 liters of diarrhea a day, and there was 1 million viruses per ml in the stool. How do you really kind of control that? You know, you're way beyond the standard infection control. That's why it was so difficult. And then try to get rid of that stuff in a hospital setting, just the medical waste. At NIH, the case they had there, they had a truckload of stuff that had been autoclaved, and none of the waste management companies would touch it. And the only reason they were able to get rid of it is they had a 40-year-old MOA with Fort Detrick that said that they could bury it on their property, and that's what they did. They took it over and buried it, but otherwise, with these agents, there's such a fear and a paranoia that you may run into those types of problems. So, this TB, they haven't really talked too much about TB, but the risk isn't always standard. It depends on your immune status. It depends on your exposure, and it also depends on whether or not you have an abnormal chest X-ray, or and if you're a recent converter. You can see that the risk changes depending upon who you're dealing with. So you just can't look at a positive and treat it necessarily the same way. There are accelerated post-exposure prophylaxis for TB. They have done a variety of studies and evaluations on this, and the Cochrane review says that they're effective, but they're more toxic, so you have to take that in consideration. Allergies I won't go into, but it is very prevalent, and oftentimes it's work limiting. People have to quit their job. It's that big of a problem. And I'm just going to skip through the allergy part of this since we're really talking about that. One thing that wasn't mentioned with Dr. Nissen, and I'm sure if you have enough time to talk about it, the checklists are very important when you're dealing with these types of exposures, because this isn't strep where you give penicillin and, game over, you can go home. You have to follow these people for months, and you have to make sure that they don't drop through the cracks, and you have to make sure that they were adequately informed as to the side effects, to the reality of how effective these treatments are going to be. And so in order to do that, I found the only way I can do it is to make a checklist and keep those files flagged in some way that they're being regularly checked by the staff to make sure that he did show up or she did show up for follow-up tests and things like that, or they did take the medication. Counseling, that they were adequately counseled too. So I want to talk about HIV, but I will, because it was done nicely, but I will say that there are some complicated situations, like you get stuck by someone who is an experienced HIV victim. He's already been through 3 regimens. So your Truvada and Centres isn't going to work for them because they've already had it and are resistant. So what you want to do is talk to the primary physician and ask them, what regimen are they on now and what is their viral load? If their viral load is 0 and they're on this regimen, that's the regimen you want to give the guy who just got stuck with that person's blood. If it's so complicated that, and there are some drugs you shouldn't be using, so I wouldn't go beyond the first, the standard Truvada and the integrase strand inhibitors without getting consultation. So you could, if you're lucky enough, you have your ID person, you can, talk to them. Otherwise, you call this 800 number, 888-448-4911. You're going to get an exhausted ID fellow from San Francisco General Hospital. He's going to tell you what you should do. And all I can say is that 90% of the time he's probably right. But if he's wrong for the 10%, you're covered because you called that person. You took it to the next level. And so no prophylaxis is 100%. They talk about 2 hours, 4 hours. I've always given it at 4 hours, but I always carried it in my credenza. And yes, I spent the $2,000 for the 2 bottles, but I also billed them for the bottles. And in biotechnology, the companies pay for the treatment and monitoring of these exposures. That may vary in hospital settings, but everything that Dr. Nissen said is correct. We also have other exposures that weren't really discussed. This particular chart from CDC is pretty much the one that I tell the residents to memorize, because that is essentially how you would manage a hepatitis B exposure. My philosophy on hepatitis C is that we're going to be monitoring these people, down up to 3 to 6 months. So I just shoot first, ask questions later. I don't necessarily get the RNA. I will get a baseline, but I don't make a decision on it because there really isn't any treatment until they get sick. And even at 6 months, if they turn positive, their liver function tests are fine. So the hepatologist isn't going to treat them until they see a reason to treat them. But at least the good news is that the treatment for hepatitis C is almost 100%. There's no prophylaxis for it, not like we see with HIV, which is $2,000, because the 12-week the 6-week prophylaxis that was being studied before it was canceled at NIH was $30,000. And the treatment for hepatitis C, the cure, is $120,000. So very expensive, but very effective, but not something that you want to give as like you would give Truvada and Centris. The last thing I want to discuss, well, 2 things. One is simian D virus, and that's from monkey bites. Most rhesus macaque monkeys have a infection that is very similar to herpes. They have blisters in their mouth. And if you take an animal, you can isolate them from the time they're born. They won't develop it, but as soon as they go into the colony, they get it because of the pruning that occurs in the colony. This thing, if a human gets it, it gives them the equivalent of rabies. And that requires treatment. So with any type of macaque, what I would do is essentially give them high-dose Valtrex at 1 gram 3 times a day for 2 weeks. And I certainly haven't seen any conversions. The last is essentially the exposure to what we call lentivirus. This is essentially HIV that's had some of its guts DNA genome pulled out, so it's not infectious. There's 1, 2, 3 generations. Each generation had more genome pulled out. It's for the first generation that we'll actually treat for as if it was an HIV infection because they have the theoretical possibility of reverting to wild strain after the infection. At the very end, you'll see a whole bunch of regulations that drive what I just said. So that's my talk on it. I hope you got something out of it. Any questions?
Yes, sir. 1 second. So
I will say that I did close my practice in January, but good news is 2 days ago I got my official job offer for Defense Health Agency at Fort Bliss. So I'll be the occupational medicine doctor that oversees the 23 states west of Mississippi. So wish me luck. I'm still living well. Yes, sir.
So I have not seen any virus conversion for the last 20 years that I've been working at Hopkins, but we see a lot of employees who are exposed to rhesus macaques. So we give them the prophylaxis for Valtrex. My question is, if they got really exposed again, how soon you could give them the prophylaxis again?
You can give them continuously.
Oh, really?
I mean, it's a mild drug. I mean, to me, I shoot first, ask questions later because it has a very low toxicity, even at that high dose of 1 gram 3 times a day for 2 weeks. They actually, even in travel medicine, if somebody has, is in Malaysia, gets bit by a macaque, I tell them get some Valtrex as soon as you can. Dr. Hilliard in Georgia State, she's the expert on the B virus, and she actually has 25 cases of chronic B virus in humans, and this presents as recurrent viral encephalitis, where they have to be treated with intravenous Valtrex. It's a horrible disease if you survive it. Okay, most people have a very high mortality with it, but that's why, you know, we're not worried about a super toxic agent, just give them the medication. And, there's a protocol, test them at 0 and 3 weeks, longer if they're having symptoms.
Yes, my last question is also the bat exposure. We also see students who are exposed to bats and they come to our clinic and get the rabies vaccine. How soon you could repeat the vaccination after you give like another 2 series of
Okay.
vaccines, rabies
So
vaccine?
for speed lunkers and for veterinarians who are dealing with dogs and cats that may be rabid or heads off and doing studies, we base it on the titer. If the titer falls below 1 to 5, they get a booster. Usually, if they're high risk, like if they're actually studying rabies, like at NIH, they get it every 6 months. But generally, it's every 2 years that they need a booster. The average person degrades their antibodies within 2 years, but we rely on the titers. So if there's ever a question, do a blood titer on them. If they're low, boost them.
Thank you.
Excellent. Thank you very much, Dr. Sauri.